So our next speaker is Dr. Andrew Dhawan. So Dr. Dhawan's a mathematician and computer science turned neuro-oncologist who now uses his background in data science to more accurately diagnose, treat, and prognosticate neurological diseases. He holds appointments in the Cleveland Clinic's Lerner Research Institute and Taussig Cancer Center, where he is assistant staff in the Rose Ella Burkhardt Brain Tumor and Neuro-Oncology Center. His research approach is interdisciplinary, having learned from experts in cancer biology, non-coding RNA biology, and evolutionary biology, alongside bioinformatics, data science, and applied mathematics. Dr. Dhawan collaborates with multiple researchers and physicians at the Cleveland Clinic and other institutions in ongoing research projects for diseases including glioblastoma, glioma, meningioma, P10, tumor syndrome, tuberous sclerosis, carcinomatosis, and of course, neurofibromatosis. And so Dr. Dhawan is going to talk about transforming care through NF research at the Cleveland Clinic. Dr. Dhawan.
Thank you so much, Gary, for the more than generous introduction. And I want to just start off by saying thank you to our patients and their advocates for being here. Their stories are so meaningful. And as we move forward in research, we're guided by their light. And so I want to start off with that notion. So my talk today is called Transforming Care Through NF Research at the Cleveland Clinic. On the right side of your screen, you'll see a picture of Superior Bridge, Detroit Superior Bridge, which many of you have probably driven over in Cleveland. And a bridge is symbolic of research, right? Because it's what bridges what people in the wet lab do, who are doing data science or culturing cells repeatedly, and what patients experience and how we can make that better. Translating that bridge, spanning that, is what I'll discuss today. I have no disclosures. So I want to start off with what is translational research. Translational research has three core approaches: developing new approaches to study disease, demonstrating their usefulness, and then disseminating their findings. And all of these are centered around our patients and what they experience. So our approach to research at the Cleveland Clinic is both pragmatic and patient-centered. Patients, families, and advocates help guide what we study, what treatments are developed, what outcomes matter most, and what research will help our patients live better and live longer lives. That's what we're immensely focused on. And so I'm going to take you through the stages of translational research, all the way from basic science to community practice level research, and give you an idea of what we're doing here at the clinic and what we're planning to be doing in the future. So starting with basic science, we're looking at a number of research questions, including how do different genetic changes lead to different disease manifestations. We learned about the fundamental biology today of NF1 and NF2 schwannomatosis, but there are nuances and variances there. Why are patients so different? What's driving that difference? And can we learn something from that? And then in NF1, a key challenge is, why do learning differences and verbal challenges occur? So understanding brain formation, brain structure from an embryologic perspective is something that we are also looking at in NF1. Obviously, drug treatments are very important in our populations. And so what drugs can be repurposed? How can we develop new drugs? And can we develop targeted and highly effective therapies for NF1 and its most important, most serious manifestations, which can include high-grade gliomas or high-grade brain tumors, or in NF2 schwannomatosis, meningiomas, schwannomas, and ependymomas. And, immune therapies have really transformed the care landscape in other types of cancer, but why not in NF? Can we give something to make immunotherapies more effective? Answering these basic questions will ultimately be translated to humans, but these are the initial questions we've started with on our basic science side. From the translational aspect, one thing I'll speak a little bit more about today is a trial that we've just finished in high-grade glioma. This included patients with all types of high-grade glioma, which includes sporadic and NF-associated high-grade glioma. We want to understand how wearable devices can be used in this patient population to measure tumor progression more accurately than scans. Moreover, we're very interested in learning about which tumors will behave badly. Not all tumors, as we all know, grow the same way. And in the same person, different tumors grow the same way. So understanding that and what imaging changes might predict different rates of growth or poor pathology is another core focus of our translational work. Lastly, we've pioneered a liquid biopsy program here where we're using spinal fluid to help decide when tumors are becoming malignant or when there's cancer affecting the spinal fluid, using DNA from the spinal fluid. That is a very novel approach, and we're learning quite a bit through that. Moving more into the translation to practice realm, we're looking at, are we making a meaningful difference with the treatments we're doing? We're measuring quality of life using validated surveys. How can we increase our reach to affected patients? Are the treatments we recommend actually helping and doing what we want for our patient population? And then, of course, with the new approvals, thinking about post-marketing surveillance and measuring disease outcomes. And lastly, thinking more about the community approach. And this starts with advocacy, because that's, what we're all here today to talk about, and also the most important thing that keeps the whole engine running of research, right? Without advocacy, we wouldn't be able to do any of this. Working within consortia, because of course 1 in 3,000 for NF1 and 1 in 25,000 for NF2, these are rare. And then involvement with clinical guideline development, industry partnerships, and measuring our impact, making sure we're doing the right things for the right people at the right time, with all the resources that we're so blessed to have here. So I promised you I'd speak a little bit about wearable devices in high-grade glioma. And so this is just an overview slide of all the ways patients are measured. And I love data. That's what you heard about in my bio, right? I love numbers and data, and that's how I see the world. And it turns out that everything around us is collecting data. How can we use that for medical purposes and to really benefit and change the way we care for patients? This is something I think is really important, and this is the motivation for our trial. So 1 in 3 US adults use a wearable device, such as a smartwatch, a fitness tracker, etc. We also track movement and actigraphy through electronic records, patient-reported outcomes, and your own smartphone in your pocket is often recording your data. So thinking about how that data can be used to benefit patients. So in this trial, what we did was we sought to determine the relationship between patient symptoms and activity and disease status. So does actigraphy, or what these wearable devices measure, actually predict an outcome that matters to patients and clinicians? And does actigraphy associate with patient disease status and what we see on the MRI? And so we enrolled 25 patients with high-grade glioma to wear an Apple Watch for about 6 months and routinely monitor all of the sensors, over 20 sensors on these watches, to better understand how these changes associate with disease. And in doing so, we learned quite a bit. We developed an app to help us do this, so we've created the infrastructure, and we've built in patient-reported outcomes. So when we apply this in the future for novel therapeutics, we'll be able to really measure at a high resolution what's happening to our patients. And so here's what we learned. Here's a brief, slide of just the early data. It hasn't been published yet. But what we learned is patients report a wide variety of symptoms as they're undergoing treatment. People report symptoms differently. There's a huge variance, and there's a huge number of days that are different in terms of some people experience quite a lot of symptoms and some people experience barely any symptoms that they're reporting. And so what we found is that there's this huge heterogeneity in high-grade glioma itself. And so better understanding that is our goal. We've also shown that as patients are in the study, we're able to see different categories of symptoms come up at different times. For instance, a lot more neurologic symptoms during the periods of radiation, and a lot of fatigue and musculoskeletal symptoms later on with chemotherapy. So wearable devices really allow for this high resolution analysis of the patient experience. And so you see here, what's in the Hubble's deep field and then what's in the James Webb telescope on the right. You can see a clear difference in how we see the universe and all that detail. And that's what these devices allow us to do in patients undergoing treatment for these very serious conditions. Applying this to patient populations like NF would be hugely important, and it's something we're aiming to do. Here's an individual case just to show you how granular we can get. This is a patient with high-grade glioma, so a tumor of the brain, who underwent chemotherapy. And we've plotted here on the graph on the left their daily step count. So every day we took a number and we said, this is how many steps you had this day, and we plotted that over time. You see natural cycles here. They're cycles at different scales. On weekends, this patient walked less than they did during the week. When it got colder or the weather was bad, they also walked less. But what's really interesting is they actually walked less before their tumor was found to have progressed. And that's a signal that we captured not once, but twice. We also showed that, if you can see in the highlighted green area, that during chemoradiation, as they had that initial dip, their step counts recovered and they started to tolerate the therapy better. These are insights that, are captured in usually just like a single sentence when you're visiting your doctor every month. But we can now capture this on a daily level at incredible detail. Not only step count, but heart rate variability, how well you're walking, how well you're standing, any symptoms you're experiencing. And getting this granularity of detail, I think will be transformative for the clinic. And in particular, I've highlighted with these arrows here the periods at which we noticed a massive change in step count. You'll see that it really, I'm going to use the mouse if I'm able to. We'll see that actually step count really decreased just before, a few weeks before, the MRI showed progression. And this was a consistent signal. So had we changed treatment earlier, perhaps we could improve the outcome. So understanding early changes before the MRI might be hugely impactful in these fast-moving diseases where we need to very quickly adapt what we do. And we've shown this reproducibly across patients over quite a lot of time. We're going to be expanding this study in the future, so look out for it. But really, this is quite exciting because it's for the first time we've really been able to not only provide the infrastructure to do this type of study, but to really show that these outcomes matter, and they probably associate more with what matters than MRIs themselves. We're able to figure out who progressed and who didn't early on, and other outcomes such as various quality of life metrics. So look out for some of that data and probably an expanded trial coming soon. And so the conclusions of this work are really that wearable devices are incredibly feasible to implement. It's a very cost-effective modality for getting high-resolution data, and implementation is actually straightforward when you have the right team. Patient-reported symptoms don't predict progression. That's something we've shown. But wearable-derived metrics change earlier than imaging changes. And no singular biometric variable was universally predictive, so you couldn't rely just on step count. That would be a little bit inaccurate. But using multimodal approaches, so having all the data from the sensors of the watch, was actually quite useful and incredibly helpful for prediction. So, to conclude, I think we have a huge opportunity in front of us with all of you and our incredible team here at the clinic. We have a path forward for NF1 and NF2 schwannomatosis, and this gives me hope. We're rapidly moving towards personalized molecular medicine and clinical care in NF. And what I want to emphasize here is that research is the engine of hope. It's hope that we have a better life for ourselves and our children and those who come after us and any others who are diagnosed with these diseases. And it's only through research that we'll be able to do this. So our research needs you. We need your help. You help participate in registries and clinical trials, and that creates a lasting impact beyond yourself. It gives a purpose, I think. You help us also set research priorities and define the next generation of clinical trials. You tell us what matters to you, and we work with that to figure out what we can do to help. That's our goal. None of this research happens in a vacuum. It happens with the help of advocacy, funding, bright young minds who we train to become scientists in the lab. We have some fun along the way. We have massive clinical teams that you've met many members of today, as well as a ton of researchers, allied health, associate staff. and nursing that makes all of this possible. This engine doesn't run with just one person. It runs with you, with our team, and we're happy to work together and continue our fight to end these diseases. So thank you so much for the opportunity to speak. It's just such a pleasure. I'm so grateful. And thank you for your attention.